Dr. Shreya is going to talk on ocular burns. This is the most common part in pediatric practice, and she will highlight all these different important points for that. Dr. Shreya. Try to visit her clinic in Gujarat, Dahod.
Thank you so much, sir.
Drushti Eye
We
Institute.
wish all to come there.
Drushti Eye Institute. बोल बोल.
Done full screen, it's not. I'll just speak on. Thanks again, Dr. Deshpande sir, for the nice introduction, and Dr. Rishi also. The thing we must also know when we are talking about pediatric patient, how children are just getting burned by chemical, and it's most common in our area, rural area, because the father sends baby to get tuna packet from the shop, and we get lot many tuna injuries. Acid, it's okay, it doesn't work, it doesn't penetrate much. Exception is hydrofluoric acid, but alkali is a worst and curse for the children when they just get burned by alkali. So you have to take care of alkali burns specially. There are lots of classification, Huggies and Roperol classification, and nowadays newer classification which involves the conjunctival involvement also. When we are talking about the management, you have to take care of all the phases like immediate phases, acute phase, early reparative, late reparative, and sequelae. So whenever there is a conjunctival burn, lots of inflammation and copious discharge will be there. Congestion, widespread necrosis of the cornea also can be seen. So you need to take care of this part as emergency response in an ophthalmic examination. You have to pour a lots of saline cedar eye wash, or sometimes we have to take Morgan lens to take the support to pour the material, and we can do just simple fluorescein examination and swipe up the fornix. Whatever material is there, you have to take it out and then examine for the limbal necrosis properly. So what is our immediate goal is promote the epithelial healing properly, reduce pain, decrease inflammation, and prevent bacterial infection. The management of grade 1 chemical injury usually is simple as erythromycin or bacitracin eye ointment, or sometimes we may have to support with topical steroid along with topical cycloplegic, but should be followed up on all each and other day. Whenever there is a grade 2 to 4, we can just support with topical steroid, long acting cycloplegic, sometimes scopolamine. It's very difficult to give scopolamine, so we give just simple cycloplegic. Topical broad spectrum antibiotic, oral tetracycline works very well here, and we have to take care of IOP control and high dose of vitamin C fortified in any soothing drops which works very well. So chemical patients you have to see daily you have to call, and sometimes you have to give progestational steroids such as medroxyprogesterone, and then comes the surgical management. So as this is a list of things we will give as an emergency response. Even if you give all the medication and still the inflammation persists, don't forget to look, double evert the lid, and you can see there is a lime particle lying under the superior fornix. That is the cause for inflammation. So whenever there is conjunctiva and cornea, there are the stages: acute loss of inflammation, copious discharge, as I said, early reparative can be first in 2 stages, and then later on it may come with symblepharon and chyloblepharon, obliteration of fornix or contracted fornix. So you need to take care of that. Surgery is usually debridement and surgery. Overall goals in the therapy is restore the corneal clarity, normalize the ocular surface, and prevent glaucoma and anterior staphyloma. So in this baby we performed, we removed the symblepharon what was there, and extensive removal of symblepharon, and then later on we put the amniotic membrane. Then we took limbal cell from the normal other eye, we distributed on this AMG, and that technique is called SLET technique, superior epithelial limbal transplant. So you have to cut, so you are taking support of other limbal stem cells also along with AMG, and this SLET technique works extremely well whenever there is a chemical burns. So this was the second day post-operative, and then later on you can say how with SLET technique improves and then cornea gets clear, which was published in this all series of techniques published in IGO from our institute. Early reparative phase in chemical burns of conjunctiva, again if there is a diplopia in symblepharon, simple symblepharectomy or with or without AMG and MMG works. So simple excision is seen here, and late sequelae there will be extensive symblepharon. So then again you have to put amniotic membranes, but you have to release all the scars and symblepharon with extensive dissection up to the back of the muscle. Sometime in children, if there is we put amniotic membrane and we may land them in amblyopia. So we have devised a newer technique. We just put central hole in the amniotic membrane itself. It acts as a pinhole, so there will not be a amblyopia. Leads, whenever there is a chemical burns for leads, socket, lacrimal area and orbit, lead, there will be immediate full thickness lead tear can be there. We have seen lots of patients with that. And then these are the sequelae. Immediate phase of the skin care, you need to take care. You can have, sometimes you have to take support of skin specialist whenever there is thermal burn or excessive lead burning with that. And then first let the edema reduce, and then patient may come up with ptosis. Again, this ptosis can be secondary to symblepharon. So again, symblepharon release. Here we have placed mucous membrane graft after symblepharectomy. So that also works very well. So this is the post-operative after 3 months, and cornea regains the clarity back. So sometime we may come across strabismus due to burns. So because that alkali has totally penetrated the muscle, and that is adhesion in muscle. So in this patient we have just put glue, we covered it with non-absorbable material, and then the freeing of the muscle movements. But don't forget to put the fornix forming suture in this kind of patient. Later on, patient may come with entropion, manage the entropion correction simply, or come with trichiasis. Then we have our own technique, which is ciliary bed transfer. We just release the whole, take out whole rows of the trichiatic lead. We just pass it through the anterior of the skin, and we transfer whole bed of this laches anteriorly. So that works very well, and there will never be a recurrence of this thing. And then properly the cornea will be clear if you do this technique. So this is the same patient after 3 months, cornea got clear. Again, sometime we may have to take mucous membrane graft. So release all the trichiatic lead, and then take mucous membrane from the mouth and then placed on the lead. So that also will take care of the keratinization which had happened due to burns. So in this girl there was lots of keratinization causing corneal opacity, and this is a simple mucous membrane grafting. Sometimes there is lots of entropion with sulcus deformity, lengthen the posterior lamella with canthotomy. Trichiasis with upper entropion, there will be a reason for sulcus deformity. Volume augmentation in this kind of patient works. Sometimes patient comes with enkyloblepharon, release the enkyloblepharon simply, and you will see the patient. Cicatricial ectropion, or patient comes with lag ophthalmos, you just simply can do tarsorrhaphy, or tarsorrhaphy along with the skin grafting must be done. So whenever there is entropion, just posterior lamella lengthening, ectropion, removal of cicatrix, trichiasis, ciliary bed transfer, and lead defect correct automatically. Orbit, I will not go into detail of it. There can be a shallow fornix, shelled fornix, obliterated fornix, wet contracted socket, or dry contracted socket. In all the things, the most important part you have to have with you is amniotic membrane. So when you put amniotic membrane and release the scar, that works. In this patient we had again put a mucous membrane graft, and that also worked very well, and then fitted with the prosthesis later on. So and as I said repeatedly, there should be fornix formation. You should not forget to put the fornix forming sutures. Sometime you have to do skin grafting. So This is a fornix forming suture along with the symblepharon ring will prevent the recurrence, or sometime you have to simply put conformer. This is an interesting baby which had a, in this baby we had done volume augmentation and fornix with amniotic membrane. So with this dermis fed graft we have put in this patient, then we did canthotomy, and this is the gratifying result we may get. But this kind of patient we have to touch sometime, and that is very, very difficult to manage. Lacrimal area I will not cover, which is already published, so we can talk later on. Thank you so much. Thanks a lot, Deshpande sir, and we are just running short of
Yeah,
time.
Dr. Shreya, you are doing an excellent job
Thank you,
and
sir.
treating
Thank
all
you
these
so much.
very most difficult cases, very difficult cases. You have used that stem cells, limbal stem cells, amniotic membrane and everything very, very